It is my pleasure and the pleasure of us all here at Mayo to welcome you, Eliseo, Dr. Pérez-Stable, to Mayo Clinic and to the Health Disparities Retreat this morning. Thank you for visiting with us.
Well, good morning, everyone, and it's a real honor and pleasure to be here with you. Dr. Green has been a very active and strong supporter of NIMHD over the course of the last almost 4 years. He's been on council, and I will miss him. So it's hard to say no when a council member, especially Eddie, asks to try to do something. And then the reality of having to fly and all that stuff and meetings come into place. So what I will plan to do with this talk is give you a sense of where NIMHD's research agenda is, because we've been going through mostly a year-long process of discussing what our areas are and how we're framing this, and really emphasize the issue of the science. So how do I advance here? Is it with this? Oh, the down. Okay, not the forward one. Okay, there we go. Oh, it's not working. This here. This one? Oh.
Try that one.
Or is it this one? There we go. All right, I found it. No financial disclosures, none before when I was at UCSF. Let's see. Can't get it to work. Sorry. So the other one, okay. So these are my objectives, really to talk about NIMHD and our vision, and then to really entertain with you plausible mechanisms that promote or impair these disparities, and to talk about some interventions. It's a mix of population and clinical context. I will present to you some global data on health issues. Just first to start with our institute, our history began in 1990 when the Office of Minority Programs was established within the Office of the Director at NIH. Dr. Lewis Sullivan was the Secretary of Health and Human Services under President Bush at that time, and it was very sort of progressive move to do this. Dr. Sullivan also appointed the first and so far only woman who's been director of NIH. In 1983, this office was renamed the Office of Minority Health Research, and John Ruffin had been named the director in 1990, and he remained so throughout this whole period until he retired in March of 2014. Probably the critical change came at the end of the Clinton presidency in 2000 when it was transitioned to a national center on minority health. So as an office, NIH offices have a budget, but they don't actually have their own grant program. They go to institutes and say, oh, you're doing this, we'd like to fund that, or they'll do a call, but the institutes have to fund them, and centers. As a center, you can have your own grant program. So the centers at NIH right now include Fogarty International Center and also the Center on Complementary Medicine. And so I think that was a big step in that direction. It was done through legislation championed by the Congressional Black Caucus, particularly Representative Louis Stokes. And then in 2010, NIMHD was born as part of the Affordable Care Act. It was one of the amendments slipped in at the end as the Senate was furiously making changes on the bill that the House had passed. I don't know if you remember that. Apparently Senator Kennedy was involved, and Senator Cardin from Maryland was the final one who did it. It was an interesting process. It actually mandated the creation of Office of Health Equity or Minority Health at every federal agency within HHS. So FDA, Center for Medicare and Medicaid Services, CDC, all HRSA, all have these offices coordinated by the Office of Minority Health. And so we meet on a regular basis, not every month, but that was the goal. And so this is and NIMHD became the representative of NIH at that table. Our mission at NIH is research, research, research. It's really advancing knowledge, inquiry. We pay some attention to training at NIMHD. Other institutes have bigger budgets, do a lot more in that space, but we're very focused on the diversity of the scientific workforce. And we're also interested in doing outreach with our communities. So I want to differentiate what we're calling minority health and health disparities research as two different and related spheres. So in minority health, we're looking at distinctive characteristics within a particular minority racial and or ethnic group in the US, and these are as listed by the US Census, which I'll go over. We believe that every minority group in the United States shares a social disadvantage of having been subject to discrimination as a common theme. This is not necessarily all equal. The legacy of slavery is particularly unique to this country. Similarly, the suffering of the American Indian population is also different, but all these groups are being subject to discrimination, as we can see in even in 2016. And then the research is the research of these factors in this group that lead to specific outcomes. And the outcomes don't necessarily have to be worse. So some of the minority groups have actually better outcomes, as you'll see. And understanding the mechanisms that gets there is actually an important part of inquiry and knowledge, so that we know what is actually working, what is well. And this is true across all groups, not just immigrant groups, which is generally where we've seen this. I think you're familiar with this concept. We're all Africans, as Dr. Collins said at our last council meeting. The out of Africa theory or hypothesis of the origin of human species as we know it, I think is well supported now by a variety of lines of thought. The South American continent was probably the last one to be populated by our current species, our current version of humans. There were others that didn't make it. But as you can see, this geographic dispersion of populations led to the development of what we now call race. And the geographic isolation of these groups did lead to evolution of different phenotypes, as well as a variety of differences in genotype as well. And I think this is and this will be with us for a while. Maybe in a certain number of generations we'll say, well, this is like ancient history now. We're all more mixed, and that may be where humans are headed. Although for a variety of social, cultural, and political reasons, it's not going to happen overnight. So it'll still be there for me. These are the census categories. And by the way, the census has just put out a public request for comment on their proposed changes for 2020. I got the link, but they're proposing two changes, which I'll mention in a minute. These are the 5 categories, plus white. So 6. And this is their terminology. They use the word white. They don't use Caucasian. Caucasian's an antiquated physical anthropology nomenclature from the 19th century that we should stop using, although you'll still see it in the literature. African American or black, so the flexibility on nomenclature is there. Asian category is very challenging. It's 30 countries, dozens and dozens of languages. It includes, I would say, 3 distinct geographic groups. The Northeast Asians, which primarily Korea, Japan, and China. Then the Southeast Asians, which may also include part of China, but also predominantly Southeast Asia, Indonesia, and the Philippines. And then South Asia, which is genetically different than the East Asian groups. And so it's a kind of a challenge to have them be in the same group. But it is what the census has. American Indian or Alaska Native, Native Hawaiian or other Pacific Islander, worth noting, are different from Asians and should not be included with Asians. So you often see Asian/Pacific Islander. That's wrong. Pacific Islanders are a very small number proportionally, except for Hawaii and maybe a little bit in California. And they're very disadvantaged in all the aspects that we usually look at, and so should be looked at separately, and need to be looked at separately. And then Latino, Hispanic, which is the group I identify with, which is a mixture different different races, and it represents 20 countries, although a similar culture and for the most part, the Spanish language origin. Health disparity populations then includes not just the racial ethnic minorities I just listed, but also people of less privileged socioeconomic status. This was an important step in the understanding and development of this. So we started out as minority health and predominantly African American health in the early part of the 90s, and this evolved to all minorities, a diversity of what minority groups are in the U.S., and then include individuals of less privileged social class. So it encompasses whites in that population, partly driven by people in Congress saying, well, my state is this way or my state is that way, but I think it's an appropriate and correct focus on the issues. And then rural residents are included. I think most rural residents who we are interested in are one of the other two groups, but they do have some particular issues. And then we have a fourth category called others subject to discrimination, and this will allow us then to emphasize populations that we believe should be in here in terms of their healthcare disparities. And so I think in the future we may see some changes in that. Now, unlike in minority health, where we're interested in whether things are good or not good, in health disparity populations, we're focused really on poor health outcomes that are linked in some way to the social disadvantage, but not exclusively explained by that, and of course lead to being underserved in the spectrum of healthcare. So in health disparities, we're always looking at conditions where the targeted group that we're interested in is doing worse. And it's not hard to find it, mind you, because poor people generally do worse than people who are better off. And in many cases, being of a minority racial ethnic group is part of that. And then the science or the research around this is to advance knowledge about what leads to this, or the mechanisms of how health determinants affect disparities. I think we're always in a rush to say, let's do something about it. And people want to do interventions. And I'm all for interventions, but we have to know what we're doing. And if we don't know the fundamental causes or the pathways or the factors that are modifiable that lead to the adverse outcome, interventions are not going to be effective and not going to be efficacious. And that is always going to set back the field because they tend to be more expensive than mechanistic studies. Assessing socioeconomic status is an essential part of what our work is about, and I would say that in general in the healthcare setting we do a terrible job of doing this, and one of the challenges going forward for all healthcare systems is to do this in a more systematic, standardized way that captures some of this variance. We're not even doing that well with race ethnicity, although I think there's more of a push in that direction. Researchers know how to do it, so you do it well in your research, you do the survey, you collect the data. The simplest way to do this is by asking 4 more years of education and then translating it into categories. It's the most robust metric that is easy. Income has issues in terms of calculation of dependence, and also people don't report it, and it loses explanatory variance as you age. Occupation is what was used in the Whitehall study in the United Kingdom, sort of to look at a gradient of health on the basis of occupation. So that's also possible, although there are numerous categories now, and in the information economy, the occupations have become more complicated. It's critical to look at life course SCS because that is beginning to get at the construct that really matters here, which is wealth. So if you're a physician, so you have the same, 2 physicians both have the same education, let's pretend they have the same income in terms of specialty, but one comes from a family as he or she is the first one in their family to go to college. Another person is a 3rd-generation homeowner in San Francisco, where property values have doubled every 10 to 15 years. So they're the same by education, same by income, occupation, but yet there's a very big difference in wealth in those 2 individuals that isn't captured by any of the things that we generally use. So the life course SCS begins to get at that. Pediatricians use parental education as a measure. And And then you're familiar with the imputed value from the census data. This is a valid method to, you get someone's zip code, you look at average census tract or median income, and then you impute that into the individual value, and you can then do research that way. This is a valid approach to get at this construct when you don't have primary data. Just remember, it's when you don't have it. So it's always better to get the primary data, in my opinion. These are the general category of outcomes. You're familiar with these higher incidence or prevalence. That's what drives a lot of our work. Premature or excessive mortality for a condition. Some measure of global burden of disease. Disability-adjusted life years is an example. This is going to be, has been widely used now in global health. We are seeing the time when this will be available in the United States by county, where you'll have race, ethnicity, gender, and age categories. And this allows you to compare the burden of disease of chronic back pain to cardiovascular disease. So chronic back pain doesn't usually lead to mortality outcomes. And then anything and everything that people or patients report, so health-related quality of life, symptom scores that have been standardized and validated, activities of daily living, etc. I think we need to use and depend on these more and more as an outcome, because after all, we're about making people feel better, not just live longer. These are just global categories. I won't dwell on these. I think most of the effort has been on the area of individual behavior, beliefs, and around the whole idea of lifestyle. Well, you get this bad outcome because you smoke. You do this because you eat too much, or you're not physically active. And I think it's fine. That's one component that we have focused on, but it has to extend well beyond that. The idea of response to stress, I think, is an important area that is developing. We now have biological tools to measure this. So on the edge of the disparities research is you grow up in a stressful environment, let's say with food insecurity, or you witness violence, you have a dysfunctional family, you live in a poor neighborhood. What does that do to you as a child? How does your system adapt to that? Some people do very well, and we need to understand why some people do very well, and then people who don't do well and then develop disease not as children but as adults, and get more prone to have diabetes when they're 45 because of experiences growing up. We now get that this is a pathway for disparities, and there are tools, whether it be allostatic load or hair cortisol or maybe telomere length or other kind of biological measures or epigenetic changes that occur that may set up the individual to do that. That leads to the promise, at least, of modifiable mechanisms. That is not a fait accompli that, oh, you grow up poor, you're going to be this way, or you grow up under discrimination, you're going to be this way. And similarly, other forms of stress, like being an immigrant or not speaking English, are important to frame in this context. The explosion of biological information in the last 20 years, I think, is something that is a remarkable advance. And where does health disparities science, where does minority health science fit into that? So 30 years ago, people would say, well, it's interesting to see that biology, but we don't know what it means when you're stressed or when you have discrimination. Now we're beginning to see ways that we can connect these and explain one or the other. In the Human Genome Project, we now have a display of how genetically similar or different people are, and what ancestral markers are about. So I think there is an opportunity there going forward. The topic of the physical environment is one that has also grown about parallel to the Human Genome Project, so it began really to see in the late 1990s. So what was the importance on health of where you live? There was a famous study in the American Journal of Public Health called the Broken Window Study, where someone went down neighborhoods and counted how many broken windows there were in a particular neighborhood and correlated that with the rates of sexual transmitted infection in that geographic area. So this is, safe neyghborhoods, good sidewalks, greenery, access to parks, access to full-service supermarkets, the physical built environment and how we interact with it. Similarly, the cultural environment, although very different, is a social interaction. So do people know their neighbors? Do they interact with the community? Some people through faith-based organizations, through other kind of sports or athletics or schools. This is the power or the importance of that in influencing health is, again, something that we kind of known for a long time. Social support is good for you. It's better for people not to be alone for their health. Survivors of heart attacks have lower recurrence when they have social support, but it was done with married men at the time, but I think it's generally the case. But there's something going on with social interactions that is positive, it can be negative as well, and now we have the tools to be able to do better measurement of that, both from a social science perspective as well as a biological one with imaging of the brain image. Not to say that we should be doing this clinically. And then the fourth space is clinical. The NIH has not been as active in the clinical space as most of you have been thinking, being in a clinical system or a medical care system, as I came from. And so I think that the clinical environment, particularly the patient-doctor communication, all the treatments that we prescribe, I'm a general internist by training, all the outcomes that get developed. So that healthcare setting, both in the hospital and urgent care and in the continuity setting and specialty care, are all important laboratories where disparities either are potentially diminished or reduced or generated. And I think this is an area that we ought to be doing more research on. Clinical research at NIH has mostly been around clinical trials. There is some health services research, particularly at the larger institutes, cancer and heart, lung, and diabetes. So just simple diagrams to make us think, and you can't see this one, about race, ethnicity, social class, and minority health and health disparities. This was sent to me by a colleague at UCSF as how they have looked at this and sort of capturing this whole set of variables. We're not, because NIMHD is our mission and what we're looking at, we have to work in all these spaces. And I think generally all the research with humans eventually lead to some sort of thinking of this type. Our program scientists at NIMHD developed this framework. This is the simplified version. There's all kinds of details that can be put into each of these boxes, but I think that transmit the complexity of what we're trying to get at the same time that you as an investigator can say, well, I'm working in this area around individual behaviors or around biological processes regarding to impact of stress. The healthcare system is in here. Both in terms of patient-doctor relationship or patient-clinician relationships, the big picture health services, looking at population science, big data, all of this is part of what we need to fit in. And it allows then for researchers to look at where they are, how do I relate to other things? And this came out of was inspired in part by an effort we did at National Institute on Aging, looking at aging and disparities research. And Carl Hill, Marie Bernard, and Norman Kaplan and I published this in a little over a year ago. That framework was simpler than this. It was focused only on aging, but you get the sense of what we're trying to develop. Let me switch slightly and begin to talk about other topics. The biomedical workforce diversity is a big priority at NIH in general, ever since Donna Ginter's paper in Science, I think in 2011 or 12. The NIH has invested a significant amount of resources in the BUILD program and also the National Research Mentoring Network, NRMN. It's an urgent societal issue. We live in a society where 40% of the population is going to identify as one of those minority groups I listed for you, and yet only about 5% of NIH grants submitted or awarded are going to African Americans or Latinos, and there hasn't been a whole lot of movement here. And these are research grants, but if you can look at the entire portfolio, it's not significantly different. Asians are well represented as a big group in terms of receiving grants compared to the representation of the population. And this is not even mentioning that a fair number of the African Americans who we are getting grants are actually African immigrants. or Caribbean black immigrants. A fair number of the Latino getting grants are not from the principal Latino groups in the US, that is Mexican, Puerto Rican, Cuban, or Central American, but there may be South Americans who, they're good. I mean, most of them are doing good stuff, and so we're happy with that, but I think we need to do more. There apparently is a bias in funding blacks that is not fully explained. This is data that we've looked at internally. We think, or Hannah Valentine is leading this effort. She's the Chief Diversity Officer in the Office of the Director of NIH. Mentoring is an issue, but actually an area that is easy to modify is that African-American investigators are half as likely to resubmit a scored grant. So if you get a grant that's scored but didn't get funded, so it means discussed and got a score, and I would arbitrarily say, anything even under 50 impact score, you really ought to resubmit that because your chances just across the board go up by a factor of 2.5 to 3, just on average. And of course, means you revise it, you respond to the reviews. And white investigators are twice as likely to do this compared to African Americans. So that's an intervention point. There's also the observation that minorities are more likely to apply in low success areas, quote unquote. And low success areas are, of course, minority health, health disparities, community health, kidney disease, hypertension. So the kinds of things that these investigators are attracted to compared to more basic science. There is more progress that has been made in the clinical arena. If you look at US med school graduates in 2014, 6% are African American. This is from AAMC, 5% are Latino, very few are American Indian, and about 20% are Asian. Those who are underrepresented minorities, so Black, Latino, American Indian, the very handful of Pacific Islanders, and then the Asian groups that we called underrepresented arbitrarily in a study we did, analysis of this data from a former UCSF student that did this. So people from Southeast Asia or the Philippines particularly, they're the ones who had enough numbers, so Vietnam and the Philippines, had a greater intent to work with underserved. So these graduating students all fill out a survey, and this is grouped over 3 years. And this was independent of their specialty choice, because primary care physicians, those who say, I'm going to go into primary care, are much more likely, 2 to 3 times more likely to work with underserved by intent. And also is adjusted for loan burden. All of these young people have an average loan burden that's 2 to 3 times what the white students have. And yet, despite that, their commitment or their intent is to work with underserved. So I think this is under review. It's not yet been published. Diversity is another important topic. I just knocked the wire down. I hope it works. Is another really critical topic, but it's different than minority health research. And NIH has, for years, just thrown all this into one bucket and say, well, you're recruiting 30% minorities in your study, we'll call that minority health. And we are going through this process now of separating this. All these populations have historically been underrepresented. It's really important. It's not just being a good investigator, or I'm going to be sensitive to my community and include a diverse sample. It's actually good science. And there are things we're not going to find out if we don't have a diverse sample. And there's now multiple examples of this. I'll share a couple with you. And we haven't had the systems at NIH to hold the investigators accountable. So I don't know how many of you have reviewed grants, but on council I got a chance to see, dozens and dozens of grants that I could look at that were on my council book. And I started to go towards the end of my time on council to the category about inclusion of women and minorities. And I never saw a reviewer sort of say inadequate. It was always a checkbox, no matter what the investigator said they were going to do. So it was just a checkbox. So and then there's no accountability. If I have a table and say I'm recruiting 35% minorities in my study, and they actually do it, there's really no recognition of that project or that investigator. And since the majority of people who say they're going to do it don't, because it's harder and it's more challenging, there's no accountability on this. And so this is an area that has gotten a little bit of traction internally. Everything's slow in government, but with the Office of Women's Health Research and interested groups. NIA is very interested in this because people over 80 don't get included in studies. The NICHD, the Child Health, is also interested because children are still understudied. And I say we have to be at the table. We have to sort of be part of it. Otherwise, you're on the menu, right? It's really harder to recruit minorities, and it takes more resources, and investigators who kind of say they're going to do it and then they get into it and they find it harder, they just got to get my sample size, forget about this. More FaceTime and more personal messages. I believe minority scientists are generally better, but we probably need to have some sort of empirical basis to make that statement. This is a belief, not based on empirical data. I mentioned the thing about the accountability, and I also think we need to end the myth that these barriers, this lack of trust, Tuskegee, this or that, or in Arizona, the Pima Indians. There are particular issues with American Indians that are different regarding to collective consent, but it isn't. All these barriers are surmountable. We can overcome them, and I think this is, unless we really become more proactive, like the biomedical workforce diversity, we're going to continue to lag way behind. Well, you can see this better than I can. Good. So switching to data, this is data from the census, from the National Center for Health Statistics. Relative risk of all-cause mortality by income, and you can see this relationship. This is not news. We've known this for a long time. Can we ever make it all one? I think not. We live in an economic system that generates inequality by its very nature. It is the only economic system that works. We've already gone through that experiment in our recent 20th century history. And so our role really is to see how we can ameliorate these and differentiate this. So you can see sort of a leveling of the effect, beginning to see a level of the effect when you get to over $115,000 a year in household income. And the average US income, I think, is around $50,000 household. So you can see that's double what the top group has. These are life expectancy data from NCHS. I don't believe they've been published yet. So a couple of remarkable points here is Latinos have the longest life expectancy. So what is that about? We don't have data on Asians, so if you're asking about that. Both men and women, they have the longest life expectancy. Yet if I show you all the social determinants in terms of percent education, income, limited English proficiency, they're all adverse. They're compared to whites. So understanding why that is, I think, is an important priority of science in this area. And it's not the immigrant paradox only, because we've been, it's only about half, a little less than half of the Latinos now are immigrants, like me. A lot of buzz about the white mortality rates starting to go up. This was observed about over a decade ago with women, and then now is also consistent with men. So the life expectancy gain for whites has been quite modest over the course of the last 15 years. But all of that, the increased mortality, is a social class effect. It's all poor whites. It's not the middle class. It's not the upper middle class or rich people. And people have tied it into mental health, substance use, suicide as the likely causes that have been associated with this. And then the other story is that African American mortality gains have exceeded expectations. So life expectancy gains have been more than would have been projected 15 years ago. Mortality rates have dropped at a faster pace than demographers or economists or health planners thought about in 2000. Yet they start off from much higher levels, so African Americans are still higher, and as you can see, life expectancy is significantly lower, but there has been significant gains. This was an example of years gain. The data on American Indians is new. NCHS has pulled together a variety of data sources to try to generate this, and you can see that disparity is greater in that racial group, but again, they haven't yet published this. Couple of studies. Chetty published this in JAMA earlier this year, a group of economists, very innovative way of looking at this. They gathered tax records that were de-identified for pre-tax household income, so they had millions of data points, and then linked it to the death registry and the Social Security Administration. They compared the richest versus the poorest 1%. So the famous 1% on top, 1% on bottom. And the gap in years of life expectancy is as shown, 10 years for women, 14.6 years for men. So the social class effect of these two extremes is quite dramatic. And this has not changed. We haven't seen improvement in this over the last 30 years. Inequality has actually increased if you compare the top 5% and the bottom 5% by 2 years for men and 3 years for women over time, driven by what I mentioned earlier about white mortality rates going up, because whites are the majority population, and poor whites are still a super important group in this country, and they are suffering disproportionately compared to the middle class and upper middle class groups. And then a fascinating observation they made was that the bottom quintile, so now we're going to 20%, in some local areas live an average of 4.5 years longer than others. So if you were in the bottom quarter, or 20% of income, and lived in Manhattan or Birmingham or San Francisco, you lived up to 4.5 years longer than if you lived in Detroit or in certain rural areas. So what's going on there? This group said it was all due to behaviors and lifestyle. Without getting in deep into the methods of how they came to that conclusion, I'm not buying that. I think we have to really look at what's different about a place. What is a place doing well that is taking better care of its most vulnerable? And that's something that I think merits further research. This is a study from a couple years ago on structural stigma and all-cause mortality in the sexual gender minority populations. And I think it also is a very innovative way of trying to get at a hard-to-measure construct. What is structural racism, or structural stigma in this case? So they looked at sexual gender minorities living in high prejudice areas, defined actually by both individual attitudes based on this general social survey, as well as states or regions that had actual explicit laws prohibiting gay marriage. This is before the Supreme Court decision, obviously. And then linked it to the National Death Index, the Social Security Administration. So SGM, living in high prejudice areas compared to the low prejudice areas, had a hazard ratio of mortality of all causes of 3. And they estimated a projected shortening of life expectancy, which is probably overestimate, but that's what they reported. And then they linked it to causes of death related to suicide, homicide, cardiovascular, and violence and cardiovascular disease. So biologically plausible causes of excess death if you're in these high prejudice areas. I think an important contribution in this area. These are cancer incidence rates across the United States, grouped up to 2012, standardized per 100,000 population and age adjusted. A couple interesting points here. The extraordinarily high rate of prostate cancer among African Americans remains a challenge, an enigma that needs more attention, although there's been progress. Also, the disproportionately high rate of lung cancer, and I'll delve into both of these a little bit. Lower rates of cancer across the board for Asian Pacific Islanders as well as Latinos in this sample. And this really crude sort of self-identified measure of race ethnicity becomes an interesting point in that there you have these dramatic differences in cancer rates. I think this slide, let's see. Well, I guess it was supposed to be there. I couldn't go back to it. What it was, I'm having trouble moving back and forth. So I'll just tell you that it was research done, funded by our institute that looked at prostate cancer gene markers. And so there are a number of markers that have been found to be associated not only with a higher rate of prostate cancer among African American men, but also more aggressive prostate cancer. And I think this is the area people are looking at: gene causes, gene environment causes, to explain what we see, 2 to 3-fold rates of prostate cancer in one racial group. These are cigarette smoking rates in the US in 2014 from CDC. Huge progress, although we've got a long ways to go. And, in the cancer moonshot, if we eliminated smoking, we'd get rid of 30% of cancer, right? So you could argue that should be the number one effort of a moonshot to decrease cancer, but it's not on there. You can see that Latinos and Asians are generally lower, particularly the women, under 10%. Some limitations of the data, of course, and multiple race is a new category CDC started using with the 2010 or so, and the rates are higher, although very few people identify in that category, only 2 to 3% in the census in 2000 and 2010. But again, you see this educational gradient. If I showed you people with graduate degrees, it's well under 5%. And that's good in a way, but it also reflects the social class gradient that we see. Let me go into this study to make a point. This is a multi-ethnic cohort study. It's funded by National Cancer Institute, and it looked at lung cancer by smoking intensity. It was done or it is actually ongoing in California and Hawaii. So the racial ethnic groups represented are listed: African American, Japanese, Latinos, Native Hawaiians, or Pacific Islanders, and whites of that particular age cohort. And then these cancer cases were identified prospectively, verified by SEER, so all pathologically confirmed or otherwise. African Americans were used as the reference group in the table I'm going to show you, and it's stratified by smoking intensity and the relative risk of lung cancer by race ethnicity within smoking level. Keep in mind that if you smoke 1 cigarette a day, you probably have a risk of lung cancer that's above never smoking. Even secondhand smoke increases your risk of lung cancer, although it's easier to quantify as you get to higher numbers of cigarettes per day. But these results, I think, are remarkable. They're over now 10 years old. So if you smoke 1 to 9 cigarettes a day, which, by the way, is half of the Latino Asians as a group, and a good proportion, maybe not quite half, but about 35% of African Americans, the risk of lung cancer for the black population was considerably higher than for Latinos, Japanese, or whites. And you can see these relative risks, they're not subtle. There's an 80% decreased risk of lung cancer for the same amount of exposure to this carcinogen. And you don't even the playing field statistically until you get to 30 or more per day. So even at a pack a day, you see this dramatic differences. So what's going on here? I don't think this has been explained. There's a variety of plausible explanations, maybe genetic factors that we haven't discovered, gene environment factors triggered by the carcinogens, metabolism differences, something I worked on, maybe partial explanation of this, although not been subsequently demonstrated. Someone always is blaming menthol because menthol brands are smoked almost exclusively by blacks and Puerto Ricans. About 70% of black smokers smoke mentholated brands. But there is not good empirical evidence linking menthol-related brands to increased risk of cancer, of lung cancer. There's some evidence for increased risk of addiction and some evidence for it being a bad brand for adolescents in terms of a starter brand. Smoking topography, how you inhale, and the amount of this was also looked at, and then whether there are protective factors that we haven't even thought of in looking at in the other groups. Oops, I went too fast again. I was going to show you the rates for cancer for women with the telling point there being looking at. I'll just keep going. Breast cancer being lower for Latino women, and share this sort of story of discovery. Based on this and the ancestral informative markers, as we identified, just to reiterate, it's about somewhere around 20% of the single nucleotide polymorphisms are unique to a particular racial group, defined by this geographic origin that we use by and large with some exceptions. The greatest heterogeneity is in people of African origin, based on this whole notion of the founder populations that we trace to maternal mitochondrial. It's sort of the idea that if you are, even though the ancestral sites will give you, you're from Spain or you're from Greece, the Europeans are more alike than different. So Southern Europe and Northern Europe are really all come from the same founder population. And then how we interact with our environment. And I think this is where a lot of the science needs to go for us to understand more about mechanisms. This is an example from early work in this area where a colleague at UCSF looked at the admixture of Latinos. Latinos are unique in a way in that Latin America was populated by indigenous people who were not completely decimated or isolated. So there were too many indigenous people. They did mix in with the Spanish. The Spanish did that more than the English in North America. And then the forced migration of African slaves, 6 million or so were brought forcibly by Europeans to the Americas, and about 4 million actually went to Latin America, to either the Caribbean or Brazil predominantly, but throughout Latin America. So you have this admixture of these three major geographic origin. This is an example of what Mexicans look like. There's about 50-50. Puerto Ricans, interestingly, and Cubans too, are more European, more white in their background, ancestral markers than people might have predicted. And there's actually more of an indigenous presence than I would have predicted. I haven't seen data from Cuba. I think in Cuba, clearly, about half the population would be considered either African mixed or black. But this is, I think, work hopefully we'll be able to do in the future. Colleagues at UCSF looked at case control studies, looked at these markers, and found that European ancestry was actually associated with a higher risk of breast cancer. And after you adjusted for all the known factors that lead to breast cancer, such as family history, biopsies, alcohol use, etc., the attenuation of the odds ratio was down to 1.39, but still significant. Similarly, similar data were reproduced in a Mexican case control sample with, again, an attenuated odds ratio of 1.20. And the epidemiology and these data were pointing, is there a gene that maybe helps explain some of this? So Laura went on this discovery analysis using samples from multiple case control studies, including the multi-ethnic cohort study that I mentioned earlier around lung cancer, and was in the pursuit of a site that would explain this. And they found a site near the estrogen receptor that was a consistent hit. They validated this with replication samples, and the findings were pretty robust, that you have about an odds ratio of 0.6 of breast cancer for the women who have this gene. Now, this gene happens to be the 6q25 gene, only present that is known so far, based on worldwide availability of data, in women with an indigenous background. So some admixture of American, call it American indigenous in the north, we call it American Indian. These are people of, they also use Amerindian as a term you see in the literature. And it's present in 15% of women with humans. So it's not rare, it's not uncommon. And it conveys apparent protection to breast cancer. So I think this is exciting mechanistically. Does it lead to any sort of change? Not yet, but it's understanding, and maybe in the future will lead to some change. Some other quick examples. I know we're going to run out of time, if I haven't already. I showed you Stevens-Johnson syndrome. This is actually from a black box warning that lists genetically at-risk populations should be screened for HLA-B 1502 prior to treating with carbamazepine, which physicians know is an old anti-epileptic drug also used in a variety of treatments of neuralgia in other contexts. So in patients with Chinese ancestors, this is what the black box says: strong association between the risk of developing Stevens-Johnson syndrome with carbamazepine treatment and the presence of this inherited variant. So one of the first times that in a pharmacogenomics perspective, a higher risk has been identified, and then they actually list the prevalence of the gene. And then if you happen to be white, African-American, Latino, or American Indian, you're not worried about this. So this is an interesting development, and perhaps for what will happen more in the future. Brief example about asthma. I borrowed this slide, as you see Caucasian listed there, where you see it affects globally a lot of people, disproportionate. Interestingly, among Latinos, Puerto Ricans have one of the highest rates known. In fact, they compete with African Americans in the U.S. for asthma, both prevalence and higher prevalence and mortality. But Mexican Americans are populations that have one of the lowest rates, and yet they're both people of Latin American origin. So what's going on there? And there's a group, there's an ongoing study of asthma in a case-control design, prospective case-control design, looking at in people living in California, Florida, Chicago, New York, and Puerto Rico to look at this. Published already is, things like self-identified race predetermine the norms for lung function. So this was in the New England Journal of Medicine, among other places, where you see the normalized curves for spirometry are different whether you are African American, white, or Mexican. And Mexican because that's what N. Haynes had, and that's what you could look at. They're Mexican Americans. You know that the creatinine is normalized to different race groups, black or non-black. We don't really know about the other groups. That's why they don't have more specifics. And related to probable differences in muscle mass, which leads to the creatinine variance. APOL1 is a big story in the nephrology world. Nephrologists who were invited me. So there are two gene variants that disproportionately affect high kidney failure rates in African Americans, and mechanisms are not fully understood. Understanding that these genes do not automatically mean you're going to get chronic kidney disease. And these genes do not mean that, that if you don't have diabetes or hypertension, it doesn't matter. Diabetes and hypertension are still more important. What these gene variants do is they double the risk within those risk strata. That's what the data show. It's not an inevitability, but it definitely is increased risk. And it is an interesting story of it was protective for the trypanosomal disease of sleeping sickness in Africa, and therefore it was selected to be sustained in the population as a consequence. One research study recently using cell culture that demonstrated a potential mechanism of loss of intracellular potassium and induction of stress-activated pathways. There's interest in the donor and transplant world because kidneys from people with APOL1 nephropathy, these risk variants are higher risk of not succeeding or earlier failure. And what it's led to is actually that recipients are not wanting to get a donor kidney from an African American because of this. And so I think it's leading to some unintended adverse consequences socially in clinical care. So rapid genotyping may be a way to address this, or you could say, well, you still get X number of years with a transplant, you're better than 3 times a week or 4 times a week dialysis. So an active area of research, NIMHD has funded some projects in this area, and there's more coming in collaboration with NIDDK. Latinos have African admixture, I just told you. So the SOUL study recently looked at this. This was just published. They looked at APOL1 alleles in the majority of about 3/4 of the sample of the SOUL study were genotyped. So a little over 12,000 adults, unrelated, and then about 40% men. You can see the mean age. The beauty of the study on Latinos is 5 national origins, so Mexican, Puerto Rican, Cuban, Central American, and Dominicans. There's also a small group of big category of South Americans. Then they looked at the Caribbean background Latinos, assuming there's more African admixture, which is a pretty safe assumption. They had a higher rate of APOL1 and sickle cell trait, and the presence of these alleles was associated with a higher risk odds ratio of developing or having albuminuria. So I think this is all done in a cross-sectional design in the baseline study. The follow-up study of this cohort study the follow-up data, I should say, are going to be available very soon, and they're already planning these. Earlier this year in the New England Journal of Medicine, this story about genetic misdiagnosis in cardiomyopathy. Hypertrophic cardiomyopathy kills people. and is a strong genetic influence. And often people who die young, and some famous athletes have died from this, so it got a lot of attention. And then if you find it early, you can usually do something about it in terms of preventing the cardiac arrhythmias that lead to death. But the original risk stratification was based on genetic testing for variants that misplace genes that really are just more prevalent among African ancestry populations in the risk panel. And so because of who they were sampling, and they received these positive reports, people with African ancestry or variants that were misclassified as pathogenic. And these researchers looked at the public access exome data, examined for overrepresented variants that were reported as causal, and showed that if blacks had been actually included in adequate numbers or even any reasonable numbers in the control groups, this would not have happened. So this led to 10, 15 years of misdiagnosis of your higher risk. You have this gene that actually was just a gene that was just more prevalent among blacks. And if they'd had an adequate control group, they would have avoided this. And it got a lot of visibility, and I think it's an important lesson. Again, well, I can't go backwards.
Let's help you out.
I'm sorry? You'll help me out? Good.
Click on previous. It should go back to the previous slide.
All right. I'm a kind of Mac person, so these machines scare me. I don't want to take up all our time, but this is policy strategies to reduce healthcare disparities. We're in a healthcare setting, so we're going through a natural experiment now, expanding access. Let's see what happens. And I think mandates research on this. It takes more than insurance. You need a place, you need a doctor, you need a clinician. There are some things that we know what to do. Public health consensus, we should just do it. The coordination of care is important, sort of the navigator in targeting high utilizers, very sick people, very vulnerable groups. This is a lesson taken from community-based research where we saw lay peer navigators help individuals with behavior change. And I think now we can adapt that to the clinical setting of the most needy patients. I don't need a navigator when I go engage with the health system, but there are many people who do, or people who get very sick. And then the construct of the patient-centered medical home, I think, is a potential mechanism by which to address healthcare disparities and have better patient-clinician communication and really emphasize cultural competence. And then the performance measurement challenge that we face is, I think if you put performance measurement, CMS is doing this now for doctors to say, well, we'll hold part of your payment to see how you do with these quality metrics. Our doctor's going to stop seeing the people who are most vulnerable because they're the potentially least likely to adhere or be the sickest group, independent of their willingness or ability to adhere. So we need to build in some sort of equity metric into this performance measurement. Hypertension, you're all familiar with. We know it's more common in people who are African American origin. Actually, Latinos now are about the same as whites. If you're a minority, extremes of age, poor, have less than a college degree, you're more likely to have uncontrolled hypertension. Similarly, you have insurance and a usual place of care, you have better control. We know from this study that the same level of systolic blood pressure in whites compared to blacks, the stroke risk is increased for blacks. And the causes for that, we don't know, but hypertension is not an equal risk across populations. So this is one of the first studies to really prove that in a prospective fashion. So the same level of hypertension, just stage 1 hypertension, so systolic under 160 and over 140, and diastolic not higher than 100, the hazard ratio for stroke was more than double for African Americans in the mid-age group and compared to whites. And so I think this is important to think about this. At Kaiser, in a study published a couple years ago in JAMA, really showed us a way that how this can be done. We should do this. We should do this in all health systems. Maybe Mayo does a great job, I don't know. So you create a registry, you look at guidelines, you say, well, this is our goal. let's make sure everyone uses effective drugs, and they use, ancient drugs maybe in some people's consideration, Thiazide and ACE. They did a combination. And they use NCQA metrics. So these are just observational metrics. How many of your patients are with hypertension are under 140/90? And they went from 43% to 80% over the course of about a little less than a decade, compared to their comparison groups that went from 55% to 64%. There wasn't anything magic about this research. It was really a standardization using EMR and creating performance metrics. They did one thing that was very person-oriented, which was that they encouraged the patients to drop in to visit their medical assistant or the LVN for checks when they weren't feeling well or when they just wanted to have a check. And then the MAs had a protocol in which to respond to, or if they really needed to, could contact their physician. This is what we should be doing in healthcare. We should look at population, look at population health. We know hypertension is not good, and if we can control it, we'll do better for the population. And we should design a system so how we can get people with hypertension controlled. And you can say the same thing about diabetes, people with cardiac disease, or high levels of cholesterol, et cetera. Diabetes is very prevalent, probably maybe the most significant chronic disease in terms of leading to morbidity and mortality. This is again a study from Kaiser, and this is more mechanistic in its findings. So after 5 years at Kaiser in this large observational study, they found that Latinos had lower rates of heart attacks, heart failure, and stroke compared to whites. Everyone had diabetes, same system, so similar therapy. We know that's not always going to be the case. But interestingly enough, more end-stage renal disease in this setting. Findings now at 10 years showed that African Americans actually had lower rates of heart attacks as well as the Asian American and Pacific Islanders pulled together, although those who are Pacific Islanders were higher and South Asians were not different. In the adjusted model, you can see where the relative risks were really quite tight and quite significantly lower compared to their white counterparts. And end-stage renal disease was more common among all minority groups except for South Asians. So it's a lesson about the heterogeneity of Asian groups. So we have to pull out the groups, and there's good rationale to pull out South Asians in diabetes in particular, but also in cardiovascular outcomes. And also a lesson that, same disease, same healthcare setting, but yet bad outcomes in both directions, but less heart attacks, more kidney disease. So what's going on there? Isn't there something mechanistic that's different about this crude category of my race or my ethnicity that leads to these differential outcomes in a condition that 20% of people over age 40 have, and it's going up. So again, a challenge to understand what is going on in this. It's not care. These are data from national data. Blacks and whites have similar process variables based on behavioral risk factor survey. You can see in terms of visits, getting tested, getting an eye exam, getting a foot exam, getting flu shot. You could argue they should be better, but there's no difference. Latinos are worse, primarily driven, I suspect, by lack of access. Let me finish with this. I think this is the last one. So precision medicine is all the buzz, Mayo in particular, right? And there's a whole conference going on. But I want to say what is more precise, individualized approach? Is it always going to be better? And we really need to prove that it's better. So one size fits all can work and to improve population health and can work in many clinical situations. So I think the challenge is not to say, let's find this specific one that's good for me, but let's make sure that we do the empirical effectiveness research, the health services research, the clinical research to demonstrate that this is better than that. New is not always better, and it's usually more expensive, and we have to keep cost in mind. And then thinking about precision medicine also in the patient-clinician interactions and how we enhance cultural competence and reduce structural discrimination. This is a study that was done about 6-7 years ago where genome-wide association studies have been predominantly of European descent. 96% of the world's studies on genome GWAS had been done in people from European descent. There's an update coming out on this. It's gone up to about 20% non-European. But guess what? All of the new state data are East Asian studies, so studies done in that part of the world. So we're still lacking in Native people, African American or Latin American populations are really, really, really low. And this is a challenge for us as well. So sorry I took so long with this, but I'm happy to, if you have time, to entertain questions and comments. Thank you for your attention.